Patient with acute abdomen can has lots of possibilities, because abdomen is just like a Pandora box and you could find lots of things. A patient can come in with a low blood pressure and you're thinking of ruptured aortic aneurysm or dissecting aorta. You could explore the aorta. Patient can come in with the very bad epigastric pain. You're thinking of acute pancreatitis and you could look at the pancreas. Patient can come in with loin to groin colicky abdominal pain and you're thinking of a renal colic and you could explore the kidney, looking for hydronephrosis as well. And patient can come in with right iliac fossa abdominal pain and you're thinking of acute appendicitis. You can dive in and take a look at the appendix. Or patient may come in with constipation, very bad abdominal pain, distended abdomen. You're thinking of bowel obstruction and you could just take a look at the whether there's any bowel obstruction by looking at the small bowel and the large bowel. Or sometimes you're thinking of perforated gastric ulcer. You could also take a look whether there's any gas. And patient may come in with right hypochondrial pain or with jaundice and you're thinking of hepatic abscess or cholelithiasis or cholecystitis. You could take a look straight away at the liver or the gallbladder. So let's just go through all those possibilities. For example, if patient come in with suspect of aortic aneurysm, you have the abdominal probe, and with the abdominal probe, whereby the arrow is towards this side, if you divide the probe towards A and B, whatever comes here on the A would correlate on this side, on the B side will correlate over there. And what you need to do is just put your probe straight there, and to locate the aorta, first of all, you know that the aorta would run from here, the abdominal aorta, from the epigastric area towards the umbilicus, where it bifurcates towards the right and left iliac, common iliac artery. So over here, with the arrow towards this side, you just put straight over the epigastric area, and you will straight away see a large shadow here, and that would correlate with the vertebra. Sitting on the vertebra would be this like a coin-like structure, which is pulsatile. That is actually your aorta, and you could run the probe downwards, yeah. And if you look at that coin, and I'm moving downwards, 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 downwards towards the umbilicus, it becomes 2. From 1, it becomes 2. So that is the bifurcation of the aorta. And if you were to freeze and measure the size of the aorta, and you'll be able to see whether it is actually aneurysmic or not. For example, here I'm going to freeze it. I'm going to measure it from outer to outer. Select. And you measure from the outer wall to the outer wall. And this is about 14.7 millimeters or 1.47 centimeters. Usually we consider it aneurysmic if it is more than 3 centimeters. As for the iliac arteries, the size would be half of that, about 1.5 centimeters. And you could also see from there, if you twist it towards the sagittal manner, you can see the whole aorta, and you could measure it along the way, and you would also be able to see whether there is any false lumens. Yeah? With the color, you can see false lumens. If there are 2 lumens, one will be false, one will be true. That would be for dissecting aneurysm. Now, that's for aorta. Now, sometimes you're worried about acute pancreatitis. What you could do is just put your probe towards the epigastric again with the arrow here. And what you see from there, if you see the aorta just now, again this is the vertebra. Sitting on the vertebra over here is the aorta. On this side is actually your inferior vena cava, which is compressible. I'm compressing it and it's compressible. But the aorta is not compressible. If you run the aorta upwards, you will find that it has a branch which is round like that. You see that small one? That is actually the superior mesenteric artery. superior mesenteric artery. And above the superior mesenteric artery, you will find that there's kind of a structure close to it, which is actually the splenic vein, which is compressible. Yeah, it's like a tadpole there. So when you find this structure, you already found your head of pancreas. Okay? So this is the area of the head of pancreas, in pancreatitis usually it's more of a hypoechoic, and if it is of a chronic pancreatitis you will see pseudocyst, and usually the echogenicity, if you find it's hypoechoic, you start to think of acute pancreatitis. You could measure the size as well of the head of the pancreas. Yeah. And typically, well, it ranges in terms of size, but typically it's around 35 millimeters over the head of pancreas, about 20 millimeters over the body, and less than 10 millimeters over the tail. If you put your probe like that and you found the head, you just need to follow it through leftwards, and you will find the body and the tail. So you will go towards the spleen actually. And sometimes it's obscured by the bowel shape. So it goes from the head, body to the tail. Yeah, over there. Now you might want to look at the kidney. If patient is complaining of that colicky abdominal pain, what you need to do is just put your probe with the arrow slanting like that towards posterior, and place it at the subcostal margin over the lateral chest or the lateral abdomen. Yeah. And from there you will be able to make out the kidney. Okay. So there you got your kidney. And this kidney, you can see whether there is any renal calculi. If there is calculi, you will see bright echogenic structure with shadow underneath it, and depends on the size. And usually with this less than 5 millimeters, the stones can pass through the urethra, but if it's more than that, may need surgical intervention. You also want to look whether there is any hydronephrosis, whereby over the medulla area you will find hypoechoic presentation, and you could differentiate that from vessels by looking at the tools. Now this is over the right kidney. If you want to look at the kidney over the other side, again with the arrow, and this time arrow pointing towards there posteriorly, but you really need to go a little bit posterior, and you can just have a look. Sometimes you may have to go in between ribs. From subcostal margin, you can go a little bit higher in between ribs to assess the kidney. So you can see the kidney, you can look whether there's any calculi, and you can see whether there's any hydronephrosis. And you could move on to just take a quick look at the bladder, because sometimes, especially if you see hydronephrosis on both sides of the kidney, there may be a common obstruction over the bladder, and you might be able to see some urethral stone along the way. If you see here, this is actually your bladder, and underneath it is your prostate. You might want to look at the liver, especially when you are thinking of hepatic abscess or cholelithiasis or cholecystitis. And how to do it is like this. we just place it again with the arrow towards this side. And the way you move your probe would be along the subcostal margin like that until you reach the lateral side of the chest. So as you move from here, you can explore it by tilting your probe, tilting your probe, tilting your probe, tilting your probe, all the way. And along the way, you'll be able to look at the liver and you'll be able to find gallbladder as well. So let's try it. Okay? So when I do it from here, from the epigastric area, I move this side and I start to explore. Increase a little bit. Okay. So I'm coming here, and sometimes your view may be obscured by bowel shadow, and you will be able to explore. Like now, if I can see the whole right lobe of the liver. Yeah. Up and down, up and down, up and down, up and down. Yeah. And I can move on and go on to take a look at the whole liver. Sometimes it's obscured by the bowel gas. I can come to this side. Yeah? And over here I can see the liver. Okay. And I can see the diaphragm, the bright echogenic structures, the diaphragm. Now, if I come down a little bit, okay, I can see the kidney. Okay, so that's the liver. Okay. And along the way, you could also try and search for the gallbladder. By the bowel shadow. We just move up. Actually, I can see part of it there at the gallbladder. Sometimes you can move one up through the ribs, and you can also make up the gallbladder. It's there. The gallbladder, and if you freeze it, you can see whether there's any cholelithiasis. It would appear echogenic with hypoechoic shadows, and you could actually measure the wall. And when you measure the wall from side to side, here is 1.7 millimeter. Usually we take 4 millimeters or more for patients who's having acute cholecystitis. So that's a way of looking for hepatic abscess or any gallbladder pathology. Apart from that, we can also explore the bowel, looking for bowel obstruction. What we can also do, because sometimes we're worried of perforated gastric ulcer, we put here straight like that in a sagittal manner over the epigastrium. You will be able to see you can see the whole left liver lobe over here, and especially during perforated gastric ulcer, you will be able to see bright air across this left liver lobe diameter. For stomach, you can run it from here in sagittal view, move it with a slanted manner over the left subcostal margin, and coming over here and until you get to the duodenum. If there is obstruction, you'll be able to see a dilated stomach with fluid filled inside. But if not, you just see air. Yeah? This is just air and not much. Yeah? And air is not a good friend for ultrasound because you can't see much structure underneath it. But this is a way to explore from part of the esophagus, stomach, down to the duodenum area. You could also assess whether there's any small bowel obstruction, whereby what you do is that you're going to move like a lawnmower over the central part of the tummy. From here, down, up, down, like that. Okay? And you can move your probe from here, and along the way you move it downwards. And you can take a look at the screen. It's just some air, some brightness, bright shadow along the way, yeah, like that. Those are just bowels, yeah? But it's not obstructed. If it is obstructed, it's going to be, there will be dilated bowel seen with thickened wall, and you will see fluid-filled structure. And you could also see that there is no peristalsis in paralysis, for example. This is small bowel. For large bowel, what you need to do is just to follow the ascending colon, like that, and twist into transverse position throughout the transverse colon, and coming down through the descending colon, and you twist it and follow the pathway of the sigmoid colon until you reach the rectum. So that's for small bowel obstruction, large bowel obstruction. As for appendicitis, you can change the probe to high frequency probe. So what you do, okay, I'm changing the probe now, to locate the appendix. Usually it's easier for patients having acute appendicitis because the wall will be inflamed. Your target is actually to find a target-like structure, and if it is usually more than 7 millimeters, it would be consistent with acute appendicitis. Appendix will be typically a blind tubular structure, and it is positioned close to the superior mesenteric artery. So to make it easier, we'll just try and locate the superior mesenteric artery. If you remember just now, the aorta will come, the abdominal aorta will come over towards the left side of the central part of the abdomen, and over the umbilical area would bifurcate towards right and left common iliac artery. So this right common iliac artery will go towards the right iliac fossa, and somewhere around the McBurney area, that is where you could locate your appendix, which is close just next to the superior mesenteric artery. So I'm going to try and locate it. So over here, if I run my probe towards the right iliac fossa around the McBurney area, I'll try to search for superior mesenteric, for the iliac artery. So I'll find that there's a pulsatile artery there. So over there, if you see closely, you will find that there is a tubular structure just next to it. So you find that there is a tubular structure, double wall, just next to it, over here. And it has a blind end. So this is likely to be the patient's appendix. And if you measure it from side to side, from the outer wall to outer wall, the size is only 2.4 millimeters. That would probably be the normal appendix. That would be on the sagittal view, but if you find it over here, if you twist it to 90 degrees, you'll probably see it in a manner of what we call target presentation, target sign presentation. So it becomes sometimes like a target sign. Yeah? So that's how you locate the appendicitis. So in a gist, we just went through the aorta, we went through the pancreatitis, we went through the kidney, we went through the liver, we went through the gallbladder, we went through the small bowel, the large bowel, we went through the stomach a little bit with the signs of perforated gastric ulcer, and we went through the appendix. So this is in a nutshell of acute abdomen ultrasound.